Everyone, and welcome back. We shall now be starting with the inaugural ceremony. I now request the following dignitaries to please come and occupy the dais. Professor Y.K. Chawla, Director of PGI. Professor Avinash Supe, President of HPB. Professor S.P. Kaushik, ex-HOD of STPGI Lucknow, and the pioneer of starting pioneer of starting surgical gastroenterology in India, or is it hepatic surgery? Professor Rajinder Singh, HOD of Department of Surgery of PGI, and Dr. T.D. Yadav, our organizing secretary. I request the dignitaries to please accept a token of gratitude. Bouquets. Professor Y.K. Chawla, please. Professor Avinash Supe. Professor S.P. Kaushik. Professor Rajinder Singh. We now have Saraswati Vandana. Please maintain silence. Okay. We first have the lighting of the lamp. I please request Professor. Request Professor Rajinder Singh to please welcome the gathering.
Good evening. Professor Chawla, Director PGI. Avinash Supe, President of Indian Chapter of Hepato-Pancreatic Biliary Association. Professor Sitaram is Secretary, he is sitting. Professor Piyush, Dr. Anu, and other esteemed member of the association. The delegates who have registered, I believe over 45 to 50 students have registered for this course, and my faculty reached in the subject as they are very prominent experts who are delivering these talks. And the program itself is very exhaustive and it covers almost all the areas in the subject. There are the areas in the liver, pancreas, and biliary system. So I've seen the program and it is very exhaustive, and those who probably are attending will get benefit in the end. And I believe they will be subjected to some sort of test and given a certificate too. So I hope they will attend in all seriousness this course. With this, I welcome you again and thank you very much.
Thank you, sir. I request Professor Y.K. Chawla to please say a few words.
Professor S.P. Kaushik, guru of most of the surgeons sitting here, Professor Avinash Supe, Professor Rajinder Singh, T.D., and my friends, Professor S.K. Mathur, Dr. Sitaram and Piyush. It's a pleasure inaugurating and being associated with this program, a one-week-long program, where looking at the faculty, I think the delegates would have a real feast. They would have the who is who in HPB surgery in the country. So as Professor Rajinder Singh has said, for the residents and for the delegates, this would be a golden opportunity to get the maximum out of each one of them. We at the Institute have entered into the liver transplant program, and we just completed the 4th liver transplant here, and it's been a fairly successful cadaveric liver transplant program. And over the year, probably the Department of Surgery is likely to get into robotic surgery as well. So whatever inputs we get from the Department of Surgery after this conference, I'm sure the administration would help you out to the maximum. So, well, I won't say much. I wish you all the best and a very happy learning over the next week. Thank you all and all the best.
Thank you, sir. Dr. T.D. Yadav will now convey the vote of thanks. Dr. Avinash Subbe, please speak a few words.
The Association of HPB Indian section, I would like to really thank the director, Dr. Yogesh Chawla, who we know for last 20 years, has more than 20 years in IHG, and he has been always contributing to the growth of hepatopancreatic biliary in the country. Thank you very much, sir, for allowing us to conduct this course here. And thank you, Dr. Rajinder Singh, for also helping, as well as Dr. Yadav for organizing the whole thing. I would like to also thank all the national faculty, as well as all delegates who have come. In a brief, in 2008 we conducted World Congress 2008, and for the proceedings of whatever that funds which we collected, we developed a trust. And the main aim of this trust is to take this HPG surgery to all over India. And therefore we have started from those interest of that particular funds, HPB courses. This is a 6-day course, mainly trying to target to promote HPB surgery all over the country. And we have been trying to choose the prime institutions like CMC Vellore, Nizams, and BGI also we feel one of the prime institutes will help us to take this our motive much further. Thank you very much, and I'm sure you'll enjoy this course. Thank you.
Thank you, sir. Professor S.B. Kaushik, sir, can you please?
Professor Chawla, Professor Rajinder Singh, T.D. Yadav, Avinash, and friends and colleagues. It's almost an emotional moment for me, but I'm so happy and satisfied to see the progress over the years which the specialty has indeed made. Grateful. Thank you very much indeed.
Thank you, sir. I request Dr. T.D. Yadav to now convey the vote of thanks.
नमस्कार, परम श्रद्धेय प्रोफेसर चावला, प्रोफेसर अविनाश सुपे, प्रोफेसर एस.पी. कौशिक जो कि मेरे गुरु भी रहे हैं, प्रोफेसर राजिंदर सिंह, प्रोफेसर सीताराम, प्रेजेंट सेक्रेटरी IHPB, प्रोफेसर माथुर सर एंड प्रोफेसर पीयूष साहनी, और मेरे और सभी दोस्त, other delegates. I have to give a vote of thanks on the behalf of Organizing Secretary from the Department of General Surgery. I take this opportunity and I just beg pardon that I wanted to use Hindi because this was all my dream that one day I should stand and dance and talk in Hindi. So इसलिए मैं सर प्रोफेसर चावला जिन्होंने कि जब पहली बार मैं आके बोला था कि सर IHPB ने हमें बोला है कि आप जो है शुरू करो एंड इस बार आप PGI में करिए, तो मैं सर के पास गया था चिट्ठी लेके, पहले प्रोफेसर राजिंदर सिंह के पास, फिर प्रोफेसर चावला के पास, और जिस तरह से सर ने बोला था कि हाँ भाई शुरू करिए और ज़रूर करिए, तो अभी जो भी हुआ है, जो भी सफलता है, जो कुछ भी है, सर आपको बहुत बहुत धन्यवाद, मैं अपने तहे दिल से शुक्रिया अदा करता हूँ। और प्रोफेसर अविनाश सुपे जो कि कई सालों से लगातार IHPB इंडिया को इनकरेज कर रहे हैं, और एक कोर्स भी आई थिंक आपका ब्रेन चाइल्ड है सर। एंड प्रोफेसर तहे दिल से मैं शुक्रिया अदा करता हूँ कि उन्होंने मेरे अंदर विश्वास दिलाया और मेरे ऊपर यकीन भी किया कि मैं ये कोर्स को ऑर्गेनाइज कर सकता हूँ अपने डिपार्टमेंट की हेल्प से। और उसके बाद प्रोफेसर सीताराम हु हैज बीन सो काइंड, और हर समय जब भी मैं कोई मेल करता हूँ तुरंत जवाब देते हैं, तो सर आपको बहुत बहुत धन्यवाद। और जितने भी हमारे सीनियर फैकल्टी है, जितने भी सीनियर फैकल्टी इन द कंट्री, पूरे देश में, जिसको मैंने मेल लिखा कि सर ये कोर्स मैं ऑर्गेनाइज करने जा रहा हूँ और आपको आना है, एक भी मेल हमें नहीं मिला कि मैं नहीं आ सकता। तो मैं सबको, कोई बहुत लोग अभी आए नहीं हैं, कई दिन बाद आएंगे, सबको तहे दिल से शुक्रिया अदा करता हूँ। डॉक्टर विकास गुप्ता जो हमारे साथ ज्वाइंट सेक्रेटरी हैं, और हमारे कोलीग सीनियर प्रोफेसर गुरप्रीत सिंह बैठे हैं, बाकी कई लोग OT में बिजी हैं, कहीं पे प्रोफेसर GR वर्मा आए थे। इस सबको मैं अपने तहे दिल से शुक्रिया अदा करता हूँ। और हमारे वो फैकल्टी जो पूरे देश और विदेश से, प्रोफेसर डॉक्टर प्रसाद इज रीचिंग टुमारो, कल आ रहे हैं, और प्रोफेसर सैनबर्ग जो कि वीरवार को आ रहे हैं, हमें अपॉर्चुनिटी नहीं मिलेगा, एक बार और सौभाग्य नहीं मिलेगा, तो मैं यही यहाँ पे खड़ा होकर उनका भी शुक्रिया अदा करता हूँ। उसके बाद जितने हमारे जूनियर और सीनियर रेजिडेंट्स रहे हैं, जिन्होंने रात दिन एक करके पिछले 2 हफ्ते से लगातार हमारे साथ भागते रहे, उनका भी मैं बहुत बहुत शुक्रिया अदा करता हूँ। और डेलीगेट जितने लोग भी यहाँ पे रजिस्टर्ड हुए हैं, बिना उनके कोई प्रोग्राम हो नहीं सकता, तो मैं आप सब लोगों का बहुत बहुत शुक्रिया अदा करता हूँ जिन्होंने कि यहाँ पे रजिस्टर्ड हुए हैं। और चूंकि मैं पहली बार कोई ऐसा भी काम ऑर्गेनाइज कर रहा हूँ, तो अगर मेरे से कोई गलती होती है, कोई ऑर्गेनाइजेशन में प्रॉब्लम होती है, तो मैं समझता हूँ कि आप लोग माफ़ करेंगे मुझे। और मेरे जितने भी कुछ 2-4 फार्मास्यूटिकल हैं जिन्होंने कि मुझे हेल्प किया है, मैं यहीं से इस स्टेज का सहारा लेके उनका भी शुक्रिया अदा करता हूँ। और अंत में मैं सबको पूरे साइंटिफिक प्रोग्राम, ऑल माय कोलीग्स, सबको थैंक्स अ लॉट टू एवरीबॉडी।
We now have the national anthem. I please request the gathering to stand. Wanted all from questions.
This is a relatively new entity because the first paper on portal hypertensive biliopathy, that time liver dust cerebrospinal appeared from this institute just in 1992. Prior to there was only few case reports. This is the first case series. So this condition you can say that it is just 20 years old. This has been known by many names, pseudocholangitis, then pseudocholangiocarcinoma, and finally the term setter as of now it is portal hypertensive biliopathy. So this condition refers to abnormalities of entire biliary tract, including intrahepatic and extrahepatic bile duct, cystic duct and gallbladder in patients with portal hypertension. This can be caliber irritability, stricture, segmental dilatation, HPB indentation, or pruning. This can be associated with the stones, varices, in a subset of patients. So this is different forms, and this is a sort of classification suggested. Type 1 involves extrahepatic bile duct, type 2 involvement of intrahepatic, type 3 both with one ductal system or both the ductal system. This is seen in all sorts of portal hypertension, but it is most commonly seen in the setting of EHPBO, in cirrhosis and NCPF. This is uncommon. Changes are usually restricted to changes are usually mild and rarely symptomatic. In the EHPBO, the most commonly left hepatic duct is involved in most of the patients. Next is right hepatic, and then there can be common bile duct strictures or carrier irritability. Associated stone will be seen in approximately 10% patients. Location left main bile duct and left hepatic duct. These are the two commonest site involved inversely in almost all the series which is available. Prevalence of portal biliopathy, this is as stated already, is more common in EHPBO. They are all leading series quoted here. It's almost 3 series from this institute, and the prevalence in EHPBO practically is universal. All series upwards of 90%. So roughly you can say that almost all patients of EHPBO will show some changes. However, the symptoms are uncommon. Only in 5 to 38% patients, average you can say 20% of the patients can be symptomatic. But all these are EHPBO patient. In cirrhosis, this is much less common. Is seen in only this is particular our series only, and in NCPF and cirrhosis this is much less common. When we did all these series are cross-sectional series. In contrast, if we go to longitudinal series, this is a surgical series of 89 patients, and ultimately symptomatic biliopathy. They have not talked of asymptomatic biliopathy. Symptomatic biliopathy was seen 3.6%, and still another series of 121 patients, and symptomatic portal biliopathy was seen in 6%. So roughly the changes in EHPBO will be universal, but only less than 10% patients possibly will develop symptomatic biliopathy. The mechanism, before going to mechanism, we see that there are two venous channels. One is paracholedochal vein of Petron, and then epicholedochal plexus of Saint. So these are in close relation, and as portal vein thrombosis occurs, these tend to dilate and form a cavernoma. So this produces compression effect, and in addition there are perforators come which are bypass channels. So they also have effect. So there are two hypotheses. One is compression hypothesis of the extrahepatic biliary tree, which is basically a soft structure, and this compression is because of collaterals. Other hypothesis of ischemic stricture. There is proponent for both, and there is evidence in favor of both, because shunt surgery results in resolution, so that signifies compression. But ischemic, there are many strictures which don't resolve, so they suggest component of ischemia. So possibly both factors are have some role there. This can be associated with choledochal varices and a stone which can be secondary to strictures, but also important that there is increased bile lithogenicity. On this, which we have paper from our own department, that bile composition and bile lithogenicity is increased in patients of EHPBO. So this is one paper from PGI only. So they are short series, but they wanted to say that what happens after shunt surgery. Point to be noted here is main impressions and indentation and caliber regularity, they tend to resolve with surgery, whereas strictures, they become milder but they tend to persist. So some role of ischemia is possibly happening. The diagnosis transabdominal ultrasound is not very accurate, will not pick up whole of changes, but most important, it will document the cavernoma, it will document the collateral, it is good for GB varices and possibly choledochal varices. But one most important information, that is availability of shuntable vein, that can be information becomes available with transabdominal ultrasound. However, MRI with MRCP, and possibly if it is combined with MR photovenography, then it is most informative, non-invasive method to assess for change of portal biliopathy, and also exact delineation of collaterals can be had from this. So this is MRCP picture where we have involvement of common hepatic duct including hilum and changes going into the left ductal system, and here we have dominantly in the common hepatic duct level, and there we have the cavernoma and collaterals in axial cuts. But ERCP remains gold standard, and ERCP, although invasive and there is risk of complication, pancreatitis, occurrence of cholangitis, but this gives us complete detail, and this will give us all the information required for further management. And in addition, this also has a therapeutic potential. Stenting can be done, stone extraction can be done. So these are the ERCP changes. Somebody has talked of different forms of portal hypertensive biliopathy. This is basically caliber irregularity with filling defect which may appear like a stone, but these are actually choledochal varices. And then this is called caliber irregularity, and there is a dominant stricture out here. So most of the patients, as stated already, will be asymptomatic. Symptoms can be related to either basic disease or symptom related to cholestasis, which is common. But there can be also symptoms related to stones in bile duct. Cholangitis is common in most of the series. In medical cross-sectional studies, these are not have come out very clearly, symptomatic in a small percentage. But if we see two series, this is a surgical series of 39 patients, and in this series, almost 61% patients had history of cholangitis, repeated episodes. This is the medical series, ERCP series, and 10 patients, and 5 of them had cholangitis. So cholangitis is common in this subset of patients and tends to be recurrent. When we talk of symptomatic versus asymptomatic, few factors are associated, like the symptomatic patients tend to be older, they tend to have longer duration of the disease, they are more likely to have associated stones, and obviously they are more likely to have strictures. Treatment of biliopathy will depend on involve the treatment of basic condition as appropriate. Asymptomatic patients possibly can just be followed up, no intervention is required. In symptomatic, if present with cholangitis, antibiotic support and supportive care, possibly associated UDCA, no randomized trials but widely used to induce some cholerasis and also to relieve symptoms, and then they can be subjected to ERCP for treatment of cholangitis. Associated stones, if there are no associated strictures, then ERCP and symptom clearance can be done, has a high success rate, although slightly higher complication rate. But when there is CVD stones associated with a stricture, the success rate becomes lower and they may require ultimately surgery. Whatever type of ERCP intervention is taken, there always carries risk of hemophilia. Definite treatment for biliary abnormality, this can be surgical or endoscopic. There is no wide series available. This is suggested algorithm by Dr. Dhiman. So basically depends on these patients. If there are CVD stone, no strictures, then they can undergo endoscopic procedures. If there are strictures, endoscopy still can be tried. Chances of success not very high. In failure, they can be subjected to surgical procedure, which can involve shunt surgery plus bilioenteric procedures. Sphincterotomy per se will not be contraindicated, but slightly higher rate of bleeding. Extraction technique varies. Most people, including our group, we prefer balloon over basket. But both have been said to be associated with hemophilia, and if hemophilia occurs, the terlipressin, nitroglycerin, they are supposed to be effective. Local therapy also can be tried. But in the literature, there is some suggestion that even balloon extraction can be associated with hemophilia. In cholangitis, there is need for quick drainage, and if ERCP is undertaken with the aim of definitive therapy, then this has to be going to be multi-session procedure. Multiple stenting, the protocol will be same as for benign biliary strictures, and this involves multi-session ERCP. with the stent exchange every 3 to 6 months, and duration of stenting has to be minimum 12 to 18 months. During initial ERCP, the biliary changes will be assessed, splenectomy, minor splenectomy will be done, strictures will be dilated, and then stents placed, preferably 10 French. Subsequent ERCP, the multiple stents need to be placed. Minimum target is 20 French, that is 10 into 2, and after 1 to 12 to 18 months of stenting, all stents can be removed and patients can be followed with LFT. Success rate in literature anywhere between 30 to 50%. We are in the process of preparing reporting data from our series. Our success rate is of the order of around 60%. This is endoscopy, one endoscopy series of available 10 patients. Here the number of ERCP, you can imagine it's a complicated affair. Somebody going on 10 sessions of ERC, somebody going 11 sessions. A mean appears to be around somewhere around 5 sessions, and most of the many patients remained on stent, some became asymptomatic on stent. So this is one particular series from Dr. Malaya Sharma's group. They reported that even with use of balloon for stone extraction, there is risk of hemophilia, and they have emphasized that actually colorectal varices get squeezed at the lower end and finally rupture. In the surgical treatment, I think next is going to be discussed. I will not be covering in detail. This is basically 2-stage procedure mostly. If there is untable vein, no untable vein, then possibly bilioventric anastomosis. In first stage, there will be shunt surgery, and in the second stage, if symptoms persist, then they can be subjected to bilioventric anastomosis. There are two series, important series. One is 39 patients, 24 had lasting improvement with shunt only, and 13 patients require second stage surgery, 11 had hepatobiliary, and 2 patients had colorectal. In contrast, the previous series, which is older series, there are 19 patients, very complicated surgery and complicated course. 10 patients had better outcome, but other 9 patients underwent multiple surgeries which are of different nature. Natural history of the disease is not so clearly defined. Symptomatic, this condition is symptomatic mainly in ESPBO and very rarely symptomatic with NCPA. Asymptomatic LFT and cholangiographic abnormality is much more common than symptomatic disease. Among ESPBO patients, risk probably increases with duration of the disease. Cholangitis is common and may be recurrent. Can progress to secondary biliary cirrhosis theoretically, but literature's long follow-up is not available. And spontaneous hemophilia is rare, but with intervention, hemophilia appears to be common. Thank you.
The topic that I was supposed to cover was when to operate on portal biliopathy. Dr. Sinha has already covered that. I want to make only one comment in addition to what he has already said, and that is, over the years we are now looking after patients with extrahepatic portal venous obstruction much better. So instead of dying of hemorrhage in the first, second decade, they are now living much longer, and they are presenting with unusual problems like portal biliopathy. That's perhaps the explanation that one could give for recognizing this disease now, with the advent of much better ways of looking after these patients. In that, he's had 2 attempts at endoscopic therapy, and he continued to have jaundice. I need some audience participation in this. Could be primary sclerosing cholangitis. Yes, a very rare diagnosis in our country. But could be primary sclerosing cholangitis. But why does he have biliary obstruction? Stones, common bile duct stones, yes. But he's little young for common bile duct stone, he's only 40. Only 40 years old. I'm not saying you can't get common bile stones at 40. Ascaris, okay? I'll accept that. Anything else? Dr. Yadav was very pleased this morning that a lot of audience participation during the question time. He has given us a big lunch. Exactly as it happened. I'm not saying it is right, but I'm saying this is what happened to the patient. So, his liver function tests show direct hypobilirubinemia, synthetic function seems to be alright. There is marginal elevation of SGOT, SGPT, alkaline phosphatase is raised. What next? Okay. Yeah, ultrasound showed cavernous transformation of the portal vein with thrombosis. Superior mesenteric vein was okay, sphenic vein was okay, a lot of collaterals in the hilum of the spleen. Left renal vein looked alright and there were gallstones. For GI-scopy, what are you looking for? Looking for varices. Okay. Anything else? MRCP. I don't know what we did. Oh, we did an MRCP. Right. So, MRCP shows biliary obstruction lower end, lot of filling defects there, some biliary dilatation. And in summary, now we have a patient 40 years old, obstructive jaundice, abdominal pain, nothing to suggest a malignant process like loss of weight, loss of appetite. Endoscopic therapy tried twice, extrahepatic portal venous obstruction, one stricture at least, with some minimal biliary dilatation and gallstones. MR venography. Okay. MR venography is very expensive in our place. DRC. Okay. CT photography. Cholecystectomy? Oh, I won't come to you. I won't come to you. We did an endoscopic ultrasound scan because of biliary dilatation. Okay? And on endoscopic ultrasound scan, there was no choledocholithiasis, there was no thickening of the common bile, distal common bile duct to say that there is a malignant process there. There was no mass lesion at the head of pancreas. Diagnosis? So, symptomatic portal biliopathy, failed endoscopic therapy. Dr. Sinha, I'm sorry, a few of your patients also will fail. Shunt surgery. Okay, fine. That's what we offered him. We offered him interposition mesocaval shunt using right internal jugular vein. Here are some pictures showing what we did. That's the superior mesenteric vein dissected out. Inferior vena cava below that. We harvested right internal jugular vein with a hockey stick incision. That's what we normally use. That's the internal jugular vein. And this is the harvest almost complete. And that's the completed shunt between the inferior vena cava and the superior mesenteric vein. There was a good fall of pressure, and on follow-up, Doppler is all right. not all of our patients are all right on follow-up. Only about 50% of our patients are all right on follow-up after a shunt. Nominal stricture for extrahepatic portal venous obstruction. About 50% of our patients are all right on one-time shunt. I think I'm going to stop here because all the other slides that I've got are a repetition of what Dr. Sinha just said. Question time. Has got a large spleen with hypersplenism. Should we have done a proximal splenorenal shunt instead of an interposition mesocaval shunt? Our preferred shunt in portal hypertension is a proximal splenorenal shunt. We're not pundits like Dr. Sani, but that's our preferred shunt. The reason why we chose interposition mesocaval shunt here is that we wanted to get a fairly profound drop. We thought that the renal vein size was a little small, the recipient vein size was a little small on the color Doppler. We rely only on color Doppler, we don't do CT scans to assess portal vasculature if we can avoid it. So that's why we chose interposition mesocaval shunt. Yes.
Was anything done to the gallstones at that time? At the time of this?
I'm scared when you say it.
No, I don't know. But does renal vein diameter really affect the problem?
I have no evidence for that. It's just that my mentor, Dr. Prakash Kanduri, used to say when the recipient vein is not very big, you flatten out the recipient vein by putting in the large splenic vein onto that. And that perhaps will cause distortion of the recipient vein and it may not receive all the blood that you put inside. I mean, it appeals to reason. He told me when I was very young, and it's kind of stuck on. I don't have evidence for that.
Actually, there is a condition, particularly in DSR, which is described for renal vein operation. Renal vein pressure is high. Your shunt is patent, but it will not be impressive. There is not much on it.
Yes. I wanted to make one other comment, I'm sorry, about Dr. Sinha's presentation. Two comments I wanted to make. First one was that extrahepatic portal venous obstruction is being looked after better, so you are seeing these problems. Second one is, there's no evidence-based therapy for portal biliopathy. Okay, numbers are very small. You have to go by common sense, and the algorithm that you put up is a very logical way to go about. I've got that in words, but it's the same algorithm. So you can't look for large series, evidence and so on. So you look at what appeals to you, what is common sense and what is within your capabilities and do it. But be very wary about doing a one-time hepatico-jejunostomy on these patients without doing a shunt. We have had to do that on 2 occasions. We got away, but it wasn't very pleasant.
And maybe side for anastomosis?
Difficult question, because this is done in pediatric age group also. It's a very difficult question. The only thing I would say is that if the vein size comes down, there is increased pressure on you to do a technically good job. It doesn't accept mistakes as easily as if the vein size is big. If you've got a big 11 millimeter splenic vein and a 10 millimeter renal vein, you can do a reasonable job and get away with it. But if your vein diameters are 7 and 7, then a strong pressure on you to do a technically absolutely perfect job. But I don't think All India Institute group doesn't turn down patients on vein size. They will shunt any patient. As long as the vein quality is all right, they will do that. One question for that.
Suppose we have to explore the bile duct in case of the portal biliopathy because of some block stent and stuck stent, and patient starts bleeding from the bile duct. So how to control it?
Okay. There are some very simple common sense strategies. Number one, post that as the first patient on your list. Don't have any appointments in the afternoon and evening. Be prepared to devote the whole day to it. Organize sufficient amount of blood. Make sure the patient is not coagulopathic. If the patient is coagulopathic, make sure you discuss it with your hematologist. Get enough products ready. Prevent hypothermia at all costs, because hypothermia will aggravate any bleeding that you have. So you must have a temperature above 36.5. So all your fluids will have to be warmed. Whatever irrigation fluids you have to be warmed. Your anesthetist must use warm fluids. You need a very good anesthetist for such a patient. You need plenty of 5-O-proline and 6-O-proline. And you need patience, you need a binocular loop. No other magic to it. It's just patience, meticulousness, meticulous dissection, and being prepared to hook every RBC or ligate every RBC and go on. That's all.
In this patient, there are stones above the block stent, and they had symptomatic bleeding. That's what that is operating. So, will you do the CBD drainage after the shunt, the same sitting, or
no?
Like, can you do it?
No. This patient had only an isolated stricture, so we treat that with a shunt. If the patient got stricture plus stone, then you are in trouble. If you got a patient with stricture plus stone and failed endoscopic therapy, you are in trouble. So that patient needs to have the stone addressed. He needs to have the portal hypertension addressed. So both have got to be addressed. So we would perhaps do an interposition mesocaval shunt with an exploration common bile duct and a biliary bypass in the same city. We do that in the same city. If there is a shuntable vein. If there is no shuntable vein, then you've got to do a direct exploration common bile duct with all these veins in the surface and in the wall. It's not fun. Better ways of earning your living. In these patients, we would just incise the anterior wall and do an anastomosis side to side. No transaction.
In the same patient scenario, don't have a STX is not patent, and we don't have a splenic vein portion. So what shunt?
If there is no shuntable vein, sorry,
this venoportal access is
not patent. If you don't have a shuntable vein, then the shunt is not an option. So then it's entirely endoscopic therapy, and if endoscopic fails, then you've got to, and there is biliary dilatation, then you can do a hepatic jejunostomy. Half. If there is no stone, then we are all right. We can do a shunt, wait to see how they do. 40% at least will come back with trouble.
How long do you prefer to wait?
That's a difficult question because these patients have got some liver dysfunction when we do the shunt. So they're not good candidates. It's not like patients with portal hypertension who bled and on whom we do a shunt. These patients are tough patients. Like in the old days when we used to operate on Budd-Chiari syndrome, they are like that. The liver decompensates quite a lot after the operation. So you carry them through that, and then maybe they leave hospital in a month or so, and and then you keep them on close follow-up and watch what happens to their liver function.
And then 50-60% of the patient won't require any treatment. Is it not an option? Is it not an option?
I think it's very difficult to give a judgment on just isolated stricture alone, whether endoscopic therapy is better or whether a shunt is better. I think there isn't enough evidence in literature for that. Anecdotally, I saw a patient, a 45-year-old lady with HPB or portal biliopathy. I gave her a referral to gastroenterology. The husband told me, "Sir, she has had 3 ERCPs. Each ERCP cost me 2 lakhs. I want an operation." So I said, "Why did the ERCP cost you 2 lakhs?" She bled. Every ERCP she bled. That severe bleeding, went into decompensation, ICU stay, cost of blood, and then she came. Okay, so it's just an isolated stricture alone is difficult. Stricture with stone, the treatment protocol is reasonably okay.
We wait at least 3 months before we would consider doing a bilioenteric analysis. So saying a shunt is not work. More often than not, we wait much longer. So patient doesn't have cholangitis, the liver function test returning back to normal, we wait. If in between the patient had a spike of fever, one intervention, one odd spike of fever, we wouldn't sort of rush in and go and do a bilioenteric analysis. I think all of us who operated on these patients have had disastrous experiences on the table and post-operatively. So these patients aren't easy to handle, and I think therefore all of us are a little skeptical. We've had the experience recently, a few months back, I've said this before also, of actually reaching the common bile duct, opening it up, but having so much bleeding and having already transfused so much blood that in spite of the fact that everybody says that once you've got to the bile duct, you must anastomose and come out. We put in a T-tube because that was the only way to control the bleeding at that point in time. We put in a T-tube and just took multiple sutures. We have an alive patient with the T-tube sticking out of her a few months after that procedure. So I think all of us are a little skeptical when we get to these patients. I don't think there are easy answers to any of these patients. We are very concerned when we have a person who's had 2, 3, 4 stents put in, and then they have an episode of cholangitis, because then we don't know. We recently lost a patient who bled after endoscopic intervention for portal biliopathy. We did an emergency shunt but lost her.
So, I mean, how do we say that this is a definite stricture on it? We usually don't have ERCPs, we have MRCPs. So what tells us that this is a definite stricture and not one of the other abnormalities that we see? So
I have 2 comments for that. One is, I don't think anybody really knows, because if you say something is a definite stricture and you do a shunt, that should become all right. So there probably is something more like ischemia, like Dr. Sinha pointed out, as far as the causation is concerned. Second comment I have got to make is, you need a dedicated GI radiologist with you who will hold your hand and take you through everything. And after you finish your operation, and you can somebody to go back to and tell the problems you've had. So each of you over a period of time learns a lot more about the subject. Both are important.